Okay, so in the last class, we discussed viral hepatitis, that is hepatotropic viruses, the viruses that predominantly or primarily involve liver and causing inflammation. We discussed different uh, pattern of morphology caused by these changes caused by these viruses while they are residing in and replicating in the liver. Now, today's topic is the hepatitis due to uh, non-infective organism. So it is a sort of a non-infectious hepatitis. There are a number of settings in which uh, liver can get inflamed even without having any organism like bacteria or virus or fungus or protozoa multiplying in it. As we all know that liver is involved and is exposed to many chemical substances and different products from the diet which are absorbed through the portal circulation. They are entering into the liver. So liver is exposed to a variety of stimuli that can induce inflammatory response within the liver. Morphologically, it may be similar to what the viral hepatitis looks like, maybe in acute or chronic cases, or clinically it may have the same similar clinical features. But non-infectious hepatitis is usually a diagnosis of exclusion when you have excluded the viral serologies in particular. Okay, if the viral serology is negative, viral serum markers like various antibodies or antigens, they are not present. And we have the evidence of inflammation of the liver plus some other, which different types of these hepatitis induce particular and specific morphological features. So in the presence of these morphological features and in the absence of the serological viral markers, we usually label these diseases as non-infectious hepatitis. The first type of hepatitis in this category, although it is not an uncommon disease, but it may affect a variety of individuals. Um, it may become a chronic hepatitis. Usually, it is a progressive sort of hepatitis. So, as all the autoimmune diseases, they are progressive in nature, uh, characterized by relapse and remissions. And it may induce chronic inflammation in the liver as well. So, the inflammation would be mainly centered or focused within the portal tracts. And there are pupils who are getting this disease due to some abnormal autoimmune response, immune response against self antigens. So self antibodies are usually present in these cases uh, with a genetic predisposition to HLA-DRB1. So the pupils who are having HLA-DRB1, uh, they are more vulnerable to develop this autoimmune hepatitis as compared to the person who do not harbor this this type of particular HLA. Beside this, there are association with other autoimmune diseases as well, and not only the diseases which are affecting liver primarily, like primary cholangitis, sclerosing cholangitis, or primary biliary cirrhosis, which are also autoimmune diseases. They may be associated with hepatitis, but systemic autoimmune diseases may be seen in having a good association with autoimmune hepatitis. And obviously, there will be antibody will be present. And if you see, So there will be autoantibodies. They will be present in cases of the autoimmune hepatitis, and usually the disease respond very well to the immunosuppressive agent. So all these features, that is the genetic predisposition, association with other autoimmune diseases, presence of autoantibodies, and therapeutic response to immunosuppression, they all indicate that this type of hepatitis is basically an autoimmune hepatitis with a female predominance. Almost 78% cases, they are affecting females, while 22% of cases, they are present in the, usually in the male. So uh, like very important female predominance is there. So almost all the features, they suggest that we are dealing with an autoimmune hepatitis. There are two types of autoimmune hepatitis, type 1 and type 2, and this typifying is based on the presence of certain antibodies. In type 1 autoimmune hepatitis, that is basically affecting middle-aged to older individual, we have those antibodies which are present in other systemic autoimmune diseases as well, like anti-nuclear antibodies. If you recall, these ANAs, they are present in, or they are usually positive in systemic autoimmune disease. The prototype is systemic lupus erythematosus and other autoimmune diseases as well. Similarly, in some individuals, anti-SMA, smooth muscle actin antibody, it may be present, or anti-SLA/LP antibody, anti-soluble liver antigen, anti-soluble liver antigen or liver pancreas LP antibody, it may be present. So again, if this antibody is present, then the person would have some autoimmune sort of pancreatitis as well. In a minority of patients, we do see anti-mitochondrial antibodies as well. When these antibodies are present, type 1 autoimmune hepatitis, the person is usually having some other systemic autoimmune diseases as well, as these nuclei, these mitochondria, and these smooth muscle actin, they are present in distributed in a variety of tissues. So uh, uh, one can have this manifestation of involvement of other organs as well. While in type 2 autoimmune hepatitis, which is mainly involving children and teenagers, so it is having the early age onset, and anti-LKM antibody, anti-liver kidney microsome 1 antibody, LKM1. This antibody is present in these type 2 autoimmune hepatitis, and this antibody is directed against, the protein called CYP2D6 and anti-liver cytosol ACL1. These are the proteins which are present freely in the cytosol of hepatocyte. So this is directed against those antibodies. These antibodies are directed against those proteins. In majority of patients, we usually have this type 2 autoimmune hepatitis if it is affecting the early age onset. Again, if we see at the morphology, this is very important because morphology is very much peculiar, and on the basis of morphology, a particular score is given to the liver biopsy, and overall score after having done serological investigations and clinical signs and clinical history and all these things, then a final score is obtained for that. That tells us about, okay, whether the patient is having some sort of autoimmune hepatitis, definitely or probably, or no evidence of autoimmune hepatitis. So morphology is important. Again, we are having, one may have acute hepatitis or chronic hepatitis, which ultimately lead to cirrhosis. Acute hepatitis is, when there is very severe hepatocyte injury with widespread confluent necrosis. So we discussed this idea of this concept, confluent necrosis, which is spreading peripherally from the central vein. And confluent areas of necrosis are usually seen if it is an acute hepatitis. So it is commonly leading to fulminant hepatitis and acute liver failure. But as liver is having enormous capability of regeneration, so scarring would be little, and the liver cells would regenerate themselves. Again, when the regeneration of the hepatocyte it takes place, the person becomes asymptomatic after a couple of, let's say, weeks or months, and then the disease is said to be having a course of remission, relapse, and then it is remitting again. Uh, Sometimes, acute hepatitis represent the first sign of the disease, and sometimes it may pass unnoticedly without causing so much damage to the liver architecture. Then a mixed pattern of marked inflammation and some degree of scarring may be seen in the early stage of disease, especially in those areas, in those patients where the acute inflammation, acute hepatitis is passed unnoticed. So, repeated bouts of acute inflammation may lead to, again, may compromise the capability of liver to regenerate, and then variable areas of fibrosis may be seen, resulting in scarring. Again, scarring, as we discussed in the previous, I think, last days, last night evening's discussion, that is fibrosis initially starts in the portal areas, then it is extending into the periportal spaces. Thirdly, is forming spikes, then bridging fibrosis, partial nodule, and complete cirrhosis. So any stage of the fibrosis may be seen, and it may be associated, or this autoimmune hepatitis may give a picture of the chronic hepatitis, in which the inflammation is mainly focused or centered within the portal triad. This repeated attacks of acute hepatitis, attempts to healing, injury, regeneration, fibrosis, then chronic inflammation, it may ultimately lead to cirrhosis, that is the formation of regenerating nodules surrounded by thick fibrous bands, which are forming complete nodules with little necroinflammatory activity. So when cirrhosis develops, necrosis of the hepatocyte is usually, it becomes very less remarkable. Inflammatory infiltrate is usually, wiped out, and only the cirrhosis, sign of cirrhosis would be there. So once there is cirrhosis, then it would be very much difficult to see if the process was initiated either as an autoimmune hepatitis, or it was an infectious hepatitis, or some other type of hepatitis. So when there is end stage liver showing cirrhosis, formation of multiple nodules, then the initial cause of this cirrhosis may not be established in a couple of cases. Typical features of autoimmune hepatitis needs to be remembered. And they should be remembered as typical features of autoimmune hepatitis. Again, I'm emphasizing on typical features that one should see while looking at the biopsy of a person suffering from autoimmune hepatitis. So there may be early scarring, severe necroinflammatory activity. Severe necroinflammatory activity means inflammation would be severe enough, and so as the process of necrosis. Necrosis is usually, mainly involving, if the inflammatory process is mainly, if it is a chronic one and is mainly centered within the portal tract, then is extending into the surrounding areas, and active hepatitis or interface hepatitis is usually very much remarkable. Sometimes it is the only sign that we see in cases of the autoimmune hepatitis. Or there may be foci of confluent necrosis, perivenular necrosis that spreads peripherally from the central vein, or bridging necrosis from central vein to portal, forming a necrosis, a bridge of necrotizing necrosis, necrotic hepatocytes. A very important finding of that is usually seen in cases of the autoimmune hepatitis is the predominant presence of the plasma cells. So if the plasma cells are appearing in the portal tract, then the diagnosis of autoimmune hepatitis should be or must be thought of, because plasma cells usually they do not respond in different infectious hepatitis or viral hepatitis. So plasma cell predominance in the mononuclear inflammatory infiltrates usually within the portal tract, and these plasma cells are quite easily seen. Some histopathologists, they are uh, very much strict regarding the use of this term, plasma cells, they are seen in the portal tract. So even if they see one plasma cell in the portal tract, so they usually label it as an autoimmune hepatitis. So anyway, scanty plasma cells or predominant plasma cells, whatever they are, but plasma cells should be present in the portal tract in order to establish a diagnosis of hepatocytes. Hepatocyte rosette formation, rosette-like appearance, regenerating hepatocytes, they usually form a rosette-like ring-like appearance instead of forming typical hepatocyte cords of one cell thing. And in the center of these rosette is usually the sinusoidal spaces. So these typical features of autoimmune hepatitis, uh, inflammation, necrosis, plasma cells plus minus hepatocyte rosette. They are usually seen in cases of the autoimmune hepatitis. So if you see in this photograph, let me go to pointer. So if we see in this photograph, we can see these plasma cells very well. We can make out that these are the plasma cells which are present in the portal tract. Lymphoplasmacytic infiltrate, basically predominantly plasma cells, plus minus some lymphocytes, they are also present. You know very well, plasma cells, for their growth and differentiation, they need some input from the CD4 plus T lymphocytes, type 2 helper T cells. So these are basically, CD4 plus T lymphocytes, and these are the plasma cells. So presence of these plasma cells in the portal tract, it indicates that we are dealing with a case of autoimmune hepatitis. And if you see here in the second photograph, there is extensive area of necrosis, lobular inflammation, or lobulitis, focal necrosis, which is extending from the uh, central vein and is extending into the peripheral region, And a very important finding, which we discussed in the previous slide as well, was the formation of rosette, with the center or the lumen of this rosette is basically formed by the sinusoids. So these regenerating hepatocytes, they form a rosette-like appearance. This is called as a rosette-like appearance. Okay, this is the rosette. This is formation of a rosette in the process of being formed. So again, this inflammation, if you look carefully, you can see plasma cell even in this magnification, although this is very less magnified, but still plasma cells can be identified even in the hepatocellular parenchyma. They are not only confined to these portal tract, but they are also present in the parenchyma as well. So these are the typical features: formation of rosettes, plasma cell which infiltrate, and extensive area of necrosis, severe type of necrosis, whether in the portal tract or in the parenchyma. They are usually the feature of autoimmune hepatitis. So on the presence of basis of different criteria, This is the simplified diagnostic criteria which was developed in 2008 by the International Autoimmune Hepatitis Group. And says that if the total score, different parameters have been scored accordingly, like 0, 1, 2, 0, 1, 2, or 1 or 2, or 0 or 2. We will discuss what are these basically criteria. So let's see. Okay, if this uh, all the whole algorithm is, if it is followed and points are calculated at the end, if we get total points of 7, so we say that 7 or anything plus that is more than 7 or 8, maximum score is 8. Of 4 criteria, 2 is the maximum score. So the maximum score is 8. If there is a 7 or 8, score is 7 or 8 of a particular patient, then we can say that this is definitely autoimmune hepatitis. If the score is 6, then we say, okay, this is probably autoimmune hepatitis, should be, confirmed by other means as well. And if the score is less than 6, either it is 5 or 4 or 3, then we can say that is not the probably it is not the autoimmune hepatitis. Look for some other cause of hepatitis. Again, in this criteria, the most important thing is the absence of, if you see, absence of viral hepatitis. Absence of viral hepatitis. If it is absent, if these viral hepatitis markers are absent, like hepatitis B surface antigen, hepatitis C antibody, IgG, IgM, core antibody, antibody, if they are absent and the patient is having hepatitis, then the score is said to be 2. If they are absent, if they are not absent, if they are present, the score is 0, because if they are present, that shows that the common thing comes first, and the patient is probably suffering from infectious hepatitis, viral hepatitis, not the autoimmune hepatitis. Another criteria is the presence of autoantibody of these ANA or ASMA, anti-smooth muscle actin antibody, or LKM antibody, if they are present and are strongly present, even in the dilution of 1:80. If they are present, then the score becomes 2. And if they are present in less dilution, only in up to 1:40, then we can say, okay, it is having a score 1. And if they are if the SLALP is positive only, and no other antibody, LKM or ASMA or AN, is present, then the score becomes 0. Similarly, we have to go for IgG or gamma globulins, because IgG is the most frequent antibody which is found in the plasma. 60% of all antibodies, they are basically immunoglobulin G. So if immunoglobulin G, again, if it is more than 1.1 time normal limit, then we can take it as a score 2. And if it is reaching the upper normal limit, almost 1 to the normal limit, then the IgG should be, then the score should be taken as 1. Then we go for liver histology. Liver histology, in the liver histology, if we are having the typical features for autoimmune hepatitis, rosette formation, plasma cells, interface hepatitis, if they are present, then we can say it is having, the score is, this is usually scored as 2. If it is compatible with autoimmune hepatitis, compatible means, okay, if it is not showing all these features, but chronic hepatitis with lymphocytic infiltrate without features considered typical, then we can say that this is basically score 1. If there is clinical diagnosis of autoimmune hepatitis. And if it is atypical, then if it is showing signs of another disease like non-alcoholic fatty liver disease or any other disease, then the score is counted as 0. Finally, we have to, add all these scores. So if the person is having antibodies, 1:2 in antibody positive LKM in stronger quantities, in larger quantities, even in the diluted serum, and the point is score is 2, IgG is more than normal, this is taken to liver histology, confirms, okay, this is typical for autoimmune hepatitis, and the viral markers are negative, then we will take it as as a strong 2 plus 2 plus 2 plus 2, it becomes 8. If you analyze this diagnostic criteria, so you can see the maximum score is 8. And if the viral factors are absent, then the score becomes 2. And if any of the viral factor is present, any of the viral serological marker is present, the score becomes 0. So in the presence of these viral markers, serological markers, maximum score would be 6. So it may be probably autoimmune hepatitis if it is, is very strongly clinician think if there is autoimmune hepatitis and viral marker are present, then it should be labeled as non autoimmune hepatitis or infectious hepatitis or viral hepatitis. Clinically, acute presentation is quite common. Fulminant hepatitis may be there. Cirrhosis is usually developed if the patient survives the fulminant hepatitis and chronic hepatitis ensues. This usually leads to cirrhosis, which is developed in almost 40% of the survivors. This is usually associated with high mortality rate and may be associated with some other diseases primarily affecting liver, like primary biliary cirrhosis or primary ascending cholangitis, which are also autoimmune diseases. In some cases, there may be overlap syndrome. Overlap syndrome means the patient would be having symptoms of autoimmune hepatitis as well as primary biliary cirrhosis or primary ascending cholangitis, which both these diseases, biliary cirrhosis and ascending cholangitis, usually present as cholestatic disease. So we will discuss these diseases in the diseases in the cholestasis lecture, which will be delivered for cholestasis. Hopefully, the next lecture would be cholestatic diseases. Then we have some other, like some other causes of hepatitis, usually drugs or toxins. And again, it may be dose dependent or it may be dose independent, unpredictable or idiosyncratic, while it may be predictable or intrinsic or dose dependent in certain cases. You might have remembered from your knowledge of the pharmacology where you learned the side effects of various drugs, and almost a large number of drugs were there which are either inducing hepatotoxicity or nephrotoxicity, either in a predictable manner or unpredictable or idiosyncratic manner. So there are a number of diseases which may be causing drug-induced or toxin-induced hepatitis. Obviously, we will not be discussing all these things, but a very common one, a couple of those common drugs, those drugs which are quite commonly used, like paracetamol, acetaminophen. We will discuss these. So, and most of the drugs, will follow the same general principle of either predictable fashion, drug-induced hepatitis, or dose-dependent drug-induced hepatitis, or it may be an idiosyncratic hepatitis. So if you see, pattern of injury may be quite variable. Pattern of injury may be quite variable. This chart is taken from Robin's pathologic basis of disease. So this is showing pattern of injury like cholestasis only, cholestasis with hepatitis, necrosis, fatty liver disease, cirrhosis, granulomatous inflammation, vascular lesions, and even tumors. Their morphological findings and examples of associated agents are given, like cholestasis even without inflammation, planned hepatocellular cholestasis, no sign of inflammation, cholestatic hepatitis nahi, sirf cholestasis. So it may be associated with contraceptive pills and anabolic steroids. Similarly, cholestasis, if it is present with inflammation, So it is usually, associated with different antibiotics. Hepatocellular necrosis may be seen in certain hepatotoxic drug like acetaminophen, aminofen, paracetamol, halothane, isoniazid, methyl dopa, phenytoin, causing massive necrosis and chronic hepatitis. Fatty liver disease, it may be due to like ethanol toxicity, valproic acid, aspirin, which is called as Rye syndrome, corticosteroids, methotrexate. So there are different drugs which may cause fatty liver disease. Similarly, when the exposure of these drugs is maximum, is prolonged, and then damage to liver, it becomes massive. Then fibrosis and cirrhosis may ensue. Obviously, but again, this fibrosis and cirrhosis will not be uh, encountered as the very first exposure of the drug or heavy exposure of the drug. It will be, but definitely associated with the prolonged exposure of the drug, usually resulting in periportal and pericellular fibrosis and ultimately cirrhosis of the liver. Alcohol, methotrexate, vitamin A, and other retinoids in a lateral, these are the drugs which are associated with fibrosis. So this chart can be learned from the, book directly, and this is showing basically these two features are rather more important. I'm sorry, I'm not good in pharmacology, so I will not be able to, comment upon these diseases in a bit detail. But the commonest disease, which is very commonly used, and if you see paracetamol is, it is dose dependent, it induces dose dependent toxicity. It is a predictable hepatotoxin, although quite commonly used as an analgesic, especially in the this post-COVID era, where we are not very much comfortable while using non-steroidal anti-inflammatory drugs. Although these non-steroidal anti-inflammatory drugs, they can cause hepatotoxicity as well, as in cases of the Rice syndrome. But since then, the use of paracetamol has been increased dramatically, and it may be associated with, hepatotoxicity. Uh, Toxic agent of the paracetamol is not the drug itself, but it is rather a toxic metabolite which is produced by the cytochrome P450 system, usually in the hepatocytes present in the zone 3. Zone 3 means the hepatocytes which are present uh, along the limiting plate. So as these hepatocytes site dies, the zone 2 hepatocyte take over this metabolic function and in turn become injured, and gradually the death of the hepatocyte, necrosis of the hepatocyte, inflammation and subsequent fibrosis. It starts from the zone 3 going to the zone 2, and when it involves the zone 1, so that means that we have the whole liver being injured. In severe overdoses, the zone of injury extends to the periportal hepatocytes, resulting in acute hepatic failure. Then we are having different drugs which are having a idiosyncratic reaction, which is not dose dependent. Among them are chlorpromazine, halothane, and some other drugs as well. Just a sentence about these drugs. These causes cholestasis in patients who are slow to metabolize it to an innocuous byproduct. Otherwise, this chlorpromazine is usually metabolized in the liver into some smaller molecule, some byproduct which can be excreted out. But when they are slow to metabolize, they cause cholestasis. They hamper the function of the liver. They cause their cholestasis, stasis of the bile within the liver, and then may be associated with cholestatic diseases or cholestatic hepatitis. Similarly, halothane, which can cause a fatal immune-mediated hepatitis. I'm sorry for the spelling mistake in this case. Fatal immune-mediated hepatitis in some patient exposed to this anesthetic on multiple occasions. So this halothane again is associated with multiple occasion. So often idiosyncratic drug reaction involve a variable combination of direct cytotoxicity and immune-mediated hepatocyte or bile duct dysfunction. So these drugs may be directly cytotoxic, or these drugs may be exerting their effects through, these immune mediation through partly metabolized, and then they are causing immune metabolism. So with this, uh, we are finishing that this topic of autoimmune hepatitis and some toxin and drugs, and we just touch the topic. Okay, what are the different drugs and chemicals that can cause cytotoxicity? But the whole main focus was basically on this autoimmune hepatitis. And remember, the morphology of autoimmune hepatitis: plasma cell, rosette formation, periportal inflammation. These three features are very prominent for the autoimmune hepatitis to be diagnosed. Then hopefully in the next upcoming lectures, we'll be discussing some other disease, like we have metabolic liver disease left. We are left with cholestatic disease. So we'll try to cover these topics as well in the forthcoming lecture. If you have any question, so you can contact me, and you can give your feedback as well. Thank you very much. Have a good day.